Realize.
Okay, so a very good evening to all of you. I welcome you all in this Cataract Symposium East chapter. And in this, we have our chairpersons, Dr. Lalit Verma, who is the president of AIOS and director Retina Services at Sindhavaside, New Delhi. We have Dr. Harbans Lal as another chairperson, who is the president-elect and director, Delhi Eye Center, and co-chairman, Department of Ophthalmology, Sir Gangaram Hospital, New Delhi. With me, we have Professor Namrata Sharma, who will be joining shortly, who is the Honorary General Secretary of AIOS and Professor of Ophthalmology at Center AIMS in the Cornea, Cataract and Refractive Surgery Services. And of course, Dr. Ajay Paul, who is the Director, BBI Foundation, Kolkata. And we have four speakers, Dr. Satyajit Sinha, who is Director and Senior Consultant, ABI Institute, Patna, and he'll be talking on planning cataract surgery in uncontrolled diabetes, role of NSAIDs. We have Dr. Nidhi Gajendra Gadkar, who is Senior Consultant, Cornea, Cataract, and Refractive Surgery Services at Kashyap Memorial Eye Hospital, Ranchi. She'll be talking on cataract and post-keratoplasty eyes. Then we have Dr. Swaroop Kumar Roy, who is Senior Eye Surgeon, Cataract and Glaucoma, Himalayan Eye Institute, Siliguri. We'll be talking on challenges in underwater IOL delivery. And Dr. Doyle Viswas, who is a Senior Consultant, Swiss Eye Foundation and Research Center, Kolkata, and she'll be talking about phakic IOL. So before we actually start, I will request
Dr. Harbans Lal.
Yeah, Dr. Harbans Lal. Okay, madam has joined.
No. We request Dr. Harbans Lal to say.
Yeah. Fine. Sir, Harbans Lal, sir, can you just say a few words before we actually start the symposium? Ma'am, would you like to say something before I'll contact Dr.
Thank you, Rajesh. And it is again a pleasure to be a part of this Cataract Symposium, an initiative which is taken by AIOS. And I'm sure we are going to have great talks. I think, Rajesh, we can start. Please, you can call the next speaker.
Okay. So, sir, join in, sir. Okay. So I request Dr. Harbans Lal, sir, to say a few words, and then we'll start the session. Dr. Lal, sir?
Yeah.
Please. So we have this Cataract Symposium East chapter. So we just want you to start the session with a few words, and then we'll start the talks.
I think that's a very good concept started by the IOS and Elargan. And we really are looking forward to excellent program by the East Zone, and they are very good speakers. So I'm sure it will be very beneficial for most of the listeners and the time to come, because it will be there for a very, very long time. So thank you very much, Elargan, and we look forward to this symposium.
Thank you, sir. Now I request Dr. Ajay Paul to take over and start the proceedings.
Thank you, Dr. Rajesh. I'd first invite Dr. Satyajit Sinha. His topic is planning cataract surgery in uncontrolled diabetes, role of NSAIDs. Yes, over to you, Satyajit. And once you finish, we could have some lively discussion, especially the role of NSAIDs have become so important in our routine cataract surgery. Also, earlier it was left to only for these difficult cases like diabetes or uveitis. So let's hear from you, Dr. Satyajit. He is a prolific speaker from Patna, as we all know, from ABI Institute.
Thank you so much, Dr. Ajay Paul, sir, for the kind introduction. I'd like to thank AIOS for giving me this opportunity. My grateful thanks to Dr. Lalit Verma, sir, Dr. Namrata Sharma, Dr. Harbans Lal, sir, and Dr. Rajesh Sinha. Can you hear me?
Yeah, we can hear you.
And you can see my slide?
Yes.
You can see your slide and we can hear you clearly.
Thank you so much. So I'll be talking about planning cataract surgery in uncontrolled diabetes And one thing which I would like to request all the attendees to note that we will be talking about uncontrolled diabetes, not only who are having a higher level of sugars and then getting it control. Now, diabetes, as we know, is India is becoming one of the major capitals in the world as far as the diabetes is concerned, and especially with after this COVID has happened, the incidence of diabetes is going to increase more with the use of steroids. So now, generally in this, we see that wherever the per capita income is higher, the incidence of diabetes is higher. Even though in this slide, as we see in the state of Bihar, the incidence of diabetes is lower, but I think it's pretty much underreported. So we have to be very careful. And I was doing a research on literature research on the endothelial cell loss in uncontrolled diabetes, and there was very limited literature that I could find regarding this. So diabetes mellitus is one of the major diseases worldwide, and the prevalence of diabetes has risen significantly in the past several decades. And post-COVID, the incidence of DM has risen many folds. Recognition of clinical manifestations of diabetes on the cornea is very important for the development of treatment strategies, especially in cases where ocular surgery is needed. Now, cataract surgery is associated with endothelial cell loss, as we all know, and uncontrolled diabetes mellitus. It used to be a contraindication, not anymore, but for refractive surgery. Nevertheless, diabetic patients who undergo cataract and LASIK are at significantly higher risk of developing post-operative epithelial complications. Although one of the major complications of diabetic eye is diabetic retinopathy, corneal diseases can not only develop in diabetic patients but are also difficult to manage, because most of the lasers and all that the retinal surgeons have to do, they have to get a good view, and for that the cornea has to be in good health for them to do a good laser. It is known that neuronal abnormalities directly affect the visual function in patients with diabetic retinopathy, but they may also be the cause of corneal changes in diabetic keratopathy. The findings of the anterior segment in eyes with diabetic keratopathy are more difficult to visualize than those of the posterior segment. When we are busy in our day-to-day regular OPD, sometimes we can miss subtle signs which are there in the cornea in patients, especially with uncontrolled diabetes. Although the cornea may appear disease-free in diabetic patients, marked biochemical and ultrastructural abnormalities altering its functions can be present. Now, we'll be talking more about the endothelial cell loss. The diabetic neurotropic keratopathy is a component of diabetic polyneuropathy and recognized to be the cause of morbidity of the cornea in diabetic patients. In addition, corneal endothelial cell damage can cause disturbances in the management of proliferative diabetic retinopathy before and after the surgery because of endothelial decompensation with bullous keratopathy. The early diabetic changes of the anterior segment include endothelial changes such as Descemet's membrane fold and pigment deposits in the endothelium. There have been only a limited number of studies that have focused on the importance of corneal diseases, especially in uncontrolled diabetics. Endothelial cell dysfunction may place the cornea at greater risk of developing endothelial decompensation with bullous keratopathy. Diagnosing diabetic keratopathy at an early stage will help initiate appropriate treatment for preventing further complications. This we all know, we have been seeing since our postgraduate days, a scheme of advanced glycation end products, accumulation and their effect on the corneal tissues. AGEs accumulate in diabetic corneal cells and induce nuclear oxidative DNA damage. And finally, the corneal cells die by apoptosis. On the other hand, AGEs accumulation enhance collagen cross-linking. Black spots enhance the AGEs accumulation in the corneal tissue. Now, this is a scheme of endothelial cell dysfunction in diabetes. Hyperglycemia reduces the activity of sodium-potassium adenosine triphosphatase of the corneal endothelial cells. This leads to morphological changes of the cells which progress to corneal decompensation. Now, patients with diabetic keratopathy have impairment of epithelial basement membranes, epithelial wound healing is compromised, epithelial stromal interactions, endothelial function is compromised, and the nerve functions are also compromised in these patients. The corneal disorders associated with diabetic keratopathy are characterized histologically by subepithelial deposits, thickening of the subepithelial basement membrane, and altered morphological appearances of the corneal epithelium and endothelium. There are not only ultrastructural changes throughout the cornea, but also alterations of the tear film in diabetic eyes, resulting in ocular discomfort, burning, and foreign body sensation. The severity of the tear film dysfunction is significantly correlated with the severity of the diabetic retinopathy. A greater tear film dysfunction in eyes with more proliferative changes of the retina. This is something which are coming in newer literatures, which show that the tear film dysfunction is associated with proliferative changes in the retina. It was suggested that one or more of the following events may lead to the alteration of the tear film and ocular surface of diabetic patients, and that could be due to the chronic hyperglycemia, corneal nerve damage, and impairment of insulin action. Patients with diabetes had less nerve fiber bundles in the cornea than healthy control subjects, possibly due to the presence of polyneuropathy. These findings may account for the decreased corneal sensitivity in the diabetic patients. Due to epithelial dysfunction, patients with diabetes and diabetic retinopathy are at increased risk for developing corneal disorders such as epithelial defects, recurrent epithelial erosions, decreased sensitivity, delayed reepithelialization, abnormal wound repair, and increased susceptibility to injury and ulcerations. There is increased corneal thickness has been reported in diabetic patients. However, the exact cause is still unknown. There are several possible explanations such as inhibition of the endothelial pump, increased stromal swelling pressure by a given thickness, or increase in the endothelial permeability. Several studies on the corneal endothelium in diabetic patients reported a decrease of the cell density with polymegathism and pleomorphism. However, the percentage of hexagonal cells in diabetic patients was not significantly different from that in non-diabetic patients. Now, protecting the ocular surface is crucial in diabetic patients due for phacosurgery because diabetes affects all the components of the tear film. The use of artificial tears lubricants are very important, especially during post-operative period. It is necessary to carefully examine functional disorders in diabetic patients suspected for the diabetic keratopathy, including disorders in the permeability of the corneal tissue before ophthalmological procedures such as cataract surgery. Even on the day we are doing biometry, it is very important that we do a random blood sugar because corneal thickness is increased in sugar levels above 300 milligram per deciliter, and this in effect can can affect the biometric calculations. And it's also very important that perioperatively we use topical non-steroidal anti-inflammatory drugs to prevent macular edema as a prophylaxis following cataract surgery. The role of perioperative non-steroidal anti-inflammatory drugs used in cataract surgery, recent literature establishes the efficacy of a newly available intracameral phenylephrine NSAID combination for pupillary mydriasis, post-operative NSAID used for preventing CME in certain high-risk populations, and post-operative NSAIDs for controlling pain and inflammation. And especially in diabetic patients, we have to be extra careful about the macular edema. However, further high-quality studies are required to determine long-term effects of perioperative NSAIDs on visual acuity and CME rates. It's very important that when you are using operating on a patient who has sugar levels above 200 milligram of deciliter, that time you should get a special consent form signed. While AIUS CME series says that you should be operating below 200 milligram per deciliter. In some studies in American Academy of Journal, they have said in clear corneal phacoemulsification surgeries, it can also be done below 300 milligram per deciliter. In conclusion, I would like to say that chondroitin sulfate and sodium hyaluronate must be used in all patients with uncontrolled diabetes undergoing phacoemulsification, and tear films also must be used post-operatively, tear drops, and a random blood sugar test must be done in all patients on the day of the surgery also, especially who we know have uncontrolled diabetes. Thank you so much for your patient hearing, and we would like to welcome all of you to Patna on 6th, 7th, and 8th of January for the AIOS midterm conference, which is due to happen in coming January. Thank you so much for your patient hearing.
Thank you, Satyajit. That was a real extensive. I think we have the cornea specialist here and Dr. Harbans Lal also here. I just asked the cornea person, Dr. Rajesh. Now, having heard all the problems that can lead to the keratopathy on the cornea, there are a lot of changes, both epithelial and the. So, how do you see those patients? How do you identify those patients that these are the patients which are susceptible to diabetic, a long-term diabetic patients, PDR and all of this, that this guy is going to have a corneal problem, even if he doesn't complain of. Do you do some special test for diabetics for the cornea?
Not really. There's no special test as far as the cornea is concerned.
Except the clinical ones?
Only the clinical ones. And the second thing is that we want to see whether the diabetes is well controlled or not. And if it's well controlled, then any past history related to, corneal symptoms or anything, then specular count we would like to do. We would like to see what is the endothelial status. The second thing that many times happens is that if you do a little bit of manipulation on the surface, then there can be, because the hemidesmosomes are weak, so there's chance of epithelial defect in these patients. So, and plus, of course, post-op corneal edema can be high because of the altered morphology of cells. It's not just the number of cells, but it's also the morphology of cells that is more significantly altered in diabetes. So if there is a significant alteration of morphology, then in such cases, we have to take all the precautions. In any case, we take all the precautions, but we have to be extra careful in using chondroitin sulfate while doing the surgery. We have to be a little deep. We don't have to, you have to be careful not to take the nucleus into anterior chamber and then emulsify. We have to do in the bag phaco. So all these things go slow, but not very slow also. Otherwise, if it's a long surgical time, then there can be again high chance of edema. All these cases, they have sometimes the risk of DMD as well. So just some extra precaution and a bit of pre-operative planning helps in preventing these corneal issues.
I think one important point is if you are doing a topical phaco, these patients should not be given drops just before the start of the surgery, not that 5, 10, 15 minutes before in a pre-operative room, anesthetic drops, because that can cause epithelial edema if you start too early. And we start anti-inflammatory in all the patients before surgery and after surgery for a week at least. And you also, anti-inflammatories are good, and I said, but you also have to keep watch if any of these patients are developing epithelial toxicity or so you need to stop them. And the incision is one of the most crucial thing when you do a diabetic, because they are more prone to infection also, and if there's a chamber fluctuation and other things. So incision at the end of the surgery, incision should be well closed.
These are one of the indications wherein I would like to prescribe post-operative preservative-free lubricants also in all the cases.
Yeah. That
would you pre-treat all diabetic patients with some lubricants, thinking about the say patient has an NPDR or not much of a retinopathy changes, but expecting some retinopathy changes post cataract surgery where we have not an NSAID before along with the lubricant, and how long would you continue these NSAIDs? Normally, there are many those susceptible patients. It has been recommended for 2 or 3 months. So, would you do that? Again, thinking about the diabetics having a corneal problem also.
Yeah, I would like to use NSAIDs for 8 weeks and lubricants as well. Lubricants for a little longer, and yeah, these patients are not only susceptible to have posterior issues like CME, etc., for which we prefer giving NSAIDs to prevent that. They are also prone to develop the surface problems. So yes.
So normally, if the visual recovery is not so good, I mean, if the patient vision is 6, 9, but patient is not very happy about his vision. So I think most of us have got OCT in our clinic. So I do run the OCT and see whether there's any mildest macular edema over there. So if there's any time patient is not feeling happy with vision, even if the vision is 6/9 or so, so I run the OCT, and of course, if there's any edema, then you got to continue with the anti-inflammatory. And if within a month or 6 weeks or maximum 2 months, if it doesn't respond, of course, you have got to use the anti-VEGF in those cases.
Sir, what is your comment about this uncontrolled diabetes patients? We offering them premium IOLs because at some stage they may develop diabetic retinopathy even if they haven't had it at the time of surgery. So what is your suggestion about premium IOLs, sir?
So if patient does not have any diabetic retinopathy, then you can actually go ahead and use the premium IOL 1. 2, in my experience, if the patient has a diabetes for say more than 20 years or 18 years or so, and if he has developed no diabetic retinopathy, then there's very remote chances of developing diabetic retinopathy, because most of these diabetic retinopathy develop between 10 to 15 years of duration of diabetes. So older patients, maybe prevention by sclerosis or whatever may be happening. So a very old patient who has got diabetes for 20 years, no diabetic retinopathy, I think there's absolutely nothing to worry. And in a younger patient, because now there's a good medication available and which can control the side effects of the diabetic retinopathy. And if the patient understands that he has to be careful about controlling his diabetes, I think you can go ahead and use the multifocal. But if the patient has got a very young patient, erratic lifestyle, I mean, the type of job they do these days, they drink every alternate day, they are traveling every alternate day. If it's in that type of a work, I will really 35 years of age, when he starts making money and he wants to enjoy his life, I think those patients are a little dicey. But older patients, I'll be more comfortable than using in a very young patient with a wrong lifestyle.
Yeah, coming to Satyajit's question, whether to go in for premium IOLs, because more and more patients are coming for premium IOLs. I think toric is not a problem, though toric is not considered a premium. But I think the lenses which, decrease contrast sensitivity, all the ring lenses, whatever brand or whatever. So as against them, there are lenses now, the so-called advanced monofocal. So if the patient wants, I think we could go in where in future there are chances of lowering contrast sensitivity, patient develops diabetic retinopathy. That's not a problem, because I mean there are talks who say that by putting a multifocal lens, you are not losing it. Whatever will happen with a monofocal, and that will happen with a multifocal. The problem with multifocal is that it is already lowered contrast sensitivity. So the slightest degree of retinopathy would lower. So anything that would lower, I think I would avoid at this point of time. And we have those lenses now coming up future. So otherwise, I think that's okay.
I guess there are 3 things actually. One is glycemic control, how good it is. Second, I'll take over from what Lal sir was telling, that if somebody, a 50-year-old patient has come to me with diabetes, having say mild, a little bit of one or few microaneurysms, and he's 50 years old, I will think about, I won't put a multifocal lens in that. But somebody who's a 65-year-old with a few microaneurysms and having a reasonable good glycemic control, I go ahead, because he may live for another 10-15 years. By the time he will have severe PDR, etc., even if the glycemic control is not good. But somebody who's 50 years old, the risk of having diabetic retinopathy by the age of 60, 65 will be much higher. So that is one consideration that I put while deciding about premium.
Yeah, I think again, Satyajit put up a point where what is the blood sugar level? I think AIS has a directive that 200 milligram, and then I think that this is the first time I heard that special consent. First time these are one of the conditions, but there would be patients, quite a lot of patients who are not controlled below 245 or 270, 280, prolonged diabetes, the HbA1c doesn't go below 8. How do you, I mean, that was a good suggestion, or I think that is that there in the AIS guideline that take a special consent for anybody above 200?
Actually, for me, 200 is actually too low a cutoff which has been given by AIS.
Absolutely.
And my personal cutoff is 250, 150, fasting 150 and PP 250. Reason is many times there's a stress induced. I mean, the patient checks in the morning at home, blood sugar level is all right. He comes to the clinic for operation, his blood sugar level goes up. So one is that if the patient has got the blood sugar level which was controlled and comes, and if it is 250 up to 250, I mean 255 to 256, I'll go ahead and do the surgery. And if the patient has got a problem in traveling, patient is very bulky, they can't bring it time and again, I will go and operate even up to 300, 350, 400, 500, whatever is the blood sugar. If patient has got a difficulty in commuting, a difficulty in coming from the far off places, and they have tried their level best and diabetologist is not able to control, patient is reluctant to use the insulin. So if there is a patient who has got a chronic defaulter, always maintains a blood sugar at a 450 or something, I will definitely go in, and particularly if he has got a mature cataract more or less in both the eyes. So it is on a compassion ground that the patient should be able to see, and if he's not able to control, and if he's not able to change his lifestyle because of the obesity. So I will operate at any level of blood sugar. But normally I keep my cutoff at 250. And that of course depends the patient's distance he has to travel. I mean, a patient has come for 200 kilometers away, the patient is next door neighbor. So even you can really ask him to come again. So we have got to take a lot of things into consideration. And many times you can wait for some time. By the time your list is ending, maybe his sugar actually comes down. I'm not very strict about this. And there are reports that there is no correlation between the adenocarditis and control of the blood sugar. There are enough of reports. Only thing is that if patient develops TAS or heavy inflammation, you need to give a steroid which can make his blood sugar go haywire. So anastomosis is not so directly related with the blood sugar level. I mean, there are reports that you can operate at a higher blood sugar level.
Thank you, sir. Thank you for those lovely inputs. Thank you, Dr. Rajesh, Dr. Alban, sir. Can we move on? I think we're already 6:30. So can we move on to our next speaker, Dr. Nidhi?
Yes, sir.
Yes, Dr. Nidhi, please.
So is my screen visible?
Yeah,
Yes.
Screen is visible and we can hear you.
A very good evening to all my seniors present here. And thank you, AIOS, for inviting me to be a part of the symposium. So I will be talking about cataract in post-keratoplasty eyes. Now, cataract surgery, as we know, can be done after an optical keratoplasty, after a therapeutic keratoplasty, or as a combined surgery in a failed graft along with endothelial keratoplasty. Now, the indications obviously is diminution of vision. The ideal timing would be after all the sutures are removed. However, we can plan the surgery early if there is an intumescent cataract or the cataract is very advanced. If there is trauma to the anterior capsule during the primary surgery, progressive shallowing of anterior chamber, or raised IOP. The challenges that are faced in post-keratoplasty eyes is that the patient might have a compromised optic disc or a concurrent posterior segment pathology, low endothelial cell count. The graft-host junction always is a weak area. There is a risk of viral reactivation, low visibility, irregular anterior chamber, which is mostly shallow, difficulty in IOL power calculation, high astigmatism, and the cataracts can be complicated. Preoperative planning is very important. Calculating the IOL power will be a challenge, and whatever type of IOL is planned, a backup PMMA rigid IOL or a 3-piece IOL should be kept. Peripalpal block should be given very slowly to prevent any graft-host junction dehiscence, or a subtenon's block can be given. And in selected cases, preoperative mannitol should also be given. If the patient has had history of viral keratitis in the past, then the surgery should be planned under antiviral cover. Counseling again is very important for subnormal visual outcomes, residual astigmatism, need for spectacles, contact lens, or additional procedures, risk of graft rejection, graft failure, or viral reactivation. Intraoperative planning, we need to use an endothelium protective soft shell technique. Intraocular fluid should be BSS or BSS plus. Pupils many a times are not fully dilating, so iris hooks or other pupil dilating devices should be used. There might be a requirement of pupilloplasty and a backup vitrectomy in case of any complication. During the surgery, we need to minimize the fluid turbulence in the anterior chamber. If a phaco is being done, then the IOP should be lowered as well as the aspiration flow rate. Anterior capsule should be stained with trypan blue, and sometimes retroillumination or endoilluminator assisted capsular access may be required. Post-operative management again is very crucial. Topical steroids should be tapered much slower than the regular surgery, and then eventually they are continued. Additional oral steroids may be given. Judicious use of NSAIDs and lubricants, adequate post-operative cycloplegia, adequate IOP control, and always watch out for any sign of graft rejection. Talking about the incisions, in little larger grafts, we can also open the junction of the graft host junction for the main incision as well as the side port. Whereas in smaller grafts, it is easier to make the incision on the host side. Sometimes when the grafts are very large, that time clear corneal incisions can also be made. So this is a case, post-keratoplasty, 4 months, cataract was advanced and anterior and posterior synechiae were present. So I planned the surgery while the sutures were on. Many a times when the posterior synechiae are released, there's an inflammatory membrane. After removing that, adequate pupillary dilatation is achieved and the surgery is quite easy thereafter. Capsular access again can be done under retroillumination, or sometimes even an endoilluminator assisted rhexis can be done. Here I'm using the illuminator externally only. So this is one case example. This is a case of a patient, one-eyed, operated for optical PK around 8 years back. Specular microscopy, we could not get any morphology, no cells were detected, and the cataract was advanced, almost brown cataract, and pupil was non-dilating, had pseudoexfoliation as well. So here I plan to do the surgery with iris hooks, but there was a lot of posterior synechiae and no place to place the hook. So first I did the synecholysis and tried stretch pupilloplasty. And sometimes this itself works, and then the dilatation was adequate, so I thought not to use the iris hooks. After removing the inflammatory membrane, always we need to stain the anterior capsule again, else the visibility will be very poor, because first time only the membrane gets stained. And the rhexis size again should be adequate according to the grade of the nucleus. This was at day 7. The graph was clear. BCVA was 6/12 and IOP was well controlled. Another case of a 54-year-old patient who underwent tectonic keratoplasty. The graft was eccentric. Patient was doing well. He was planned for a suture removal, but then he missed a follow-up and came with a very high IOP and intumescent cataract. And thus, before suture removal, first I planned the cataract surgery. So here I was more comfortable with SICS because of the eccentric graft, and the superior region had the graft host junction. So I made the incision a little superior nasal. Side port incision also was made such that it did not interfere with the graft host junction. Now, while doing SICS or phaco, we need to take care that the incision that we are making does not cross or dehisce the graft host junction. Nucleus delivery can be done with a vectis or viscoelastic assisted, whatever is comfortable to the surgeon. But all manipulations should be only done via the side port to avoid any anterior chamber collapse. It's important to always suture the ports here because the host cornea also does not have that much of tenacity to hold such large incisions. This is at day 14. BCVA was 6/12. IOP was much controlled with anti-glaucoma, but by that time the disc had compromised a little bit, was 0.6. And the specular count was also satisfactory. Another complication which can happen with sutures or without sutures is graft-host junction dehiscence, and excessive manipulation and increase in IOP even with the sutures caused a dehiscence here, which can require more than one sutures. So that needs to be taken care of while doing manipulation. Another case of a patient who underwent tectonic keratoplasty and the iris was excised. There was a large iris defect. She again was planned cataract surgery later, but came with an intumescent cataract and thus planned to do the surgery early with the sutures on. The surgery was uneventful, but I thought that the iris defect can cause an optic capture or can cause imbalance in the IOL. So I tried to pull all the iris and cover it over the optic at least 0.5 mm, but because of the deficiency of the iris, it was not possible. So a simultaneous pupilloplasty was done. Here a single fourth row technique was done, single pass fourth row. There was an iridodialysis inferiorly, so I could not repair more than that. But still, post-operatively at day 7, uncorrected vision was 6/12, not improving. Well-controlled IOP, and the IOL was very much in place. Graft was okay, and SFT was in place. So this can be done concurrently with the surgery, and sometimes even when we have normal as in cataract surgeries, due to long-term dilatation of cycloplegics, there can be an optic capture. And this can lead to a lot of glare and chances of the haptic also coming out. So a sequential SFT can be planned in such cases, which also gives good results. So to conclude, cataract surgery post-keratoplasty might be challenging, but careful preoperative, intraoperative, and postoperative care can give us good results. Thank you so much.
Thank you, Dr. Nidhi. There was a wonderful plethora of cases, that those challenging cases which you have managed, and especially. So before we start the discussion, I think Dr. Rajesh should add something to, especially the biometry part. When you have the sutures on versus, the sutures are already off and patient, the eye has, stabilized to a large extent, the keratoma, the corneal curvature has stabilized versus the ones that you had to put in with the sutures on. Yes, Dr. Rajesh?
Yeah. Very nice presentation, Nidhi. Wonderful cases, and I must say that. Apart from biometry, first of all, just a couple of things I would like to add here, that we should try to avoid the graft-host junction at all costs, either go in or go out, but avoid the graft-host junction. That is one. As far as the biometry is concerned, yes, ideally speaking, we should always do it after removal of complete all the sutures. But there are some scenarios wherein, as she showed, that if there is an intumescent cataract, total white cataract, in such a case, if we have to do it, then we cannot think of implanting premium IOL. We have to implant a spherical IOL only and a monofocal IOL. And therein we can calculate based on the axial length and whatever biometry we are getting, because we cannot do any change. We cannot think of any other parameters. Now, there are ways of doing it, that if somebody has a record that how much astigmatism he gets after keratoplasty in his, say, last 100 cases, and these are theoretical things, actually. practically speaking, it is very difficult to say because it also depends on many other factors. That if you have done a full thickness keratoplasty, what was the indication of keratoplasty? Again, for that reason also the astigmatism will vary. So all these things are theoretical. So we have to consider that only. We have to think about the spherical power correction, and later on, if there is any significant astigmatism after removal of sutures, we can handle it later, depending upon on the cornea or piggyback lens or whatever. So these things can be done. But when the sutures are intact there, we have to do it that way only. That is
So, Nidhi, I got one question. I mean, if you do the keratometry before removal of the suture and after the removal of the suture, so whether before removal of the suture, cornea is steeper or flatter? I mean, once you remove the suture, does cornea become flat or steep?
So that depends on how central the graft is, how eccentric the graft is, and what was the preoperative astigmatism. Many a times, because of coupling effect, even the steeper will become flat, but the flat can change. So I cannot.
No. My question was entirely different.
Yeah,
I'm not talking of the toricity, okay? Because toricity we cannot decide once there are so many sutures there. Okay, so let's forget about putting the toric IOL. So overall, the cornea is steeper initially before removal of the suture. That means when you are doing a biometry, which side to err upon, right? You will not know one. There are two factors. One is that usually the graft is bigger than the host. So that pushes it. Secondly, whenever you tie suture, when we used to do extracapsular cataract extraction, so we used to explain whenever there is a loosening of the suture, so it becomes flatter because it has become a part of a bigger circle because the globe has become bigger. And whenever there is a tightening, the whole of the eyeball total has become shorter. So that becomes a steeper. Most of the surgeons will try to give a tighter suture than a loose sutures over there. And loose in any case, you will not leave it over there. So the chance of when you are erring, that you remember that after removal of the suture, the cornea may become flatter. So if you need to do adjustment, you do adjustment accordingly. Like if you want to err on the IOL power calculation, which side to err on. That's it. Like when you are doing DSEC, so we know that it adds the tissue over there, patient becomes hypermetropic. So you need to use a little more IOL power, approximately by a diopter or so patient you feel will need DSEC, or you are doing a DSEC along with it. So you need to use little more IOL power to compensate for the hypermetropia which you are going to cause.
Yeah, that's very true. In DSEC, we can definitely plan for it, but in a full thickness graft wherein we have 16 sutures, sometimes we can have a bizarre result. 10 diopter of steepened axis, you remove 2 sutures in that axis, suddenly that becomes flatter by 3 diopters.
This is what I'm telling.
Full thickness graft.
Say if there is a loose suture, it will not cause change in the keratometry because loose suture is doing nothing. But the tight suture will make the things flatter afterwards because tightening is causing steepening. So if you see the dimpling on the cornea on a slit lamp, that means the suture is too tight and you will see the astigmatism over there. Okay, so that is what I'm trying to tell you, that if you're not already started analyzing, you can start analyzing your keratometric values before and after suture removal, so that in the future you can plan what way to put the IOL and what side to err upon. So it is not exact science, but still you will have some idea what is to be done.
Yeah, there's one.
Sutures are too tight.
Yeah, one more thing.
What we used to do. I mean, I'm not doing a keratoplasty, but this is what I used to plan my extracapsular cataract section. I used to analyze what is happening.
Mm-hmm. And what Nidhi had pointed out very rightly, that if we are doing like most of these were full thickness graft only. So if we are doing a cataract surgery in a full thickness graft, we should know the exact etiology for which full thickness graft was done. If it was related to keratitis, like corneal scar because of, say, healed viral keratitis or a mixed kind of an infection. In such cases, before, we should start acyclovir tablet prophylactically in these cases, because the risk of recurrence of herpetic infection is very high after the surgery. And of course, the second thing is that we have to protect the endothelium. So there are two major things apart from other surprises. One is failure because of endothelial failure. Second is rejection because of recurrence of herpetic infection because of the recurrence. So these two things have to be carefully handled. And the third thing, as I mentioned earlier, that we should try to avoid the graft-host junction unless there is a very, say, in temporal part, you have a very, as Dr. Lal was mentioning, that you have a very steep area. In such a case, you won't mind opening up the incision and put a suture so that that becomes a little flatter and you get a better configuration. Otherwise, you have a very bad contour. Like today only, I have a case of cataract with keratoplasty who has 16 diopter of astigmatism. And now this 16 diopter of astigmatism has happened after removal of complete sutures, all the sutures. So now there is no suture. So that is a tricky situation.
This is because of the waist gap created in the cornea. So you will have to go and tighten, put the suture again. So if you put on a suture, you can see where there is a gap, and now OCT is available. But at that time, this is how we used to analyze that if it is because of the gap over there, that astigmatism cannot be corrected by removal of the suture.
No, there's no gap, sir. There's no history of that. But sometimes what happens that the fibrosis, sometimes the sutures, if they are not exactly radial and slight non-radial, it causes a torsion in the cornea. And that torsion, after complete healing, it remains like that.
Yeah, you're right.
Once we had
1 millimeter of torsion can cause 10 diopter of astigmatism. Base suture 1 millimeter wrong, and 2 corneas, it can cause 10 diopter of astigmatism. So that's, of course, very much possible.
Sure.
Thank you, Dr. Nidhi. I think it really opened up a lot.
Well, overall, well done, Nidhi. Excellent cases you have shown, and excellent surgical hand.
Very nice cases.
Very nice videos.
Discussion, especially the your surgery skills were beyond single pass, both those. I mean, we normally don't bother, which is somehow chala gaya, pupil is dilated, but I think that was excellent. So can we have the next speaker, Dr. Doyle Biswas? I think she'll be going to the next stage. That's the Feki Kaival. She's a consultant, a cataract and refractive surgeon from Shushruta Eye Hospital, Kolkata. Over to you, Dr. Doyle. I think you have to unmute. Yeah. Yes, we can see the slides.
Good evening, everyone. And it's really an honor to share space with such learned speakers. I'm not talking exactly on cataract, but very close cousin of cataract, the Feki Kaival, which is done to get rid of our glasses.
Dr. Doyle, can you make it full screen?
Yeah.
It is okay.
Yes.
That's it.
So there is a spectrum of refractive surgery. We have the cornea-based refractive surgery, the lenticular-based refractive surgery, and of course the combined. And the Feki Kaival falls under the lenticular-based refractive surgeries. So in a history of Feki Kaival, the first model was made by Fyodorov in 1980s in Russia, and the first implant was done as late as 1993. Now there are different types of Feki Kaivals, the anterior chamber, the iris-supported Feki Kaivals, but the ones that I'm talking about are the plate lenses that fit between the iris and the crystalline lens, just in that space. Now, what are the advantages of these posterior chamber IVLs, and why didn't the others be so successful? To begin with, they're behind the iris, which means that they're far away from the corneal endothelium. This provides excellent cosmosis, and it has a greater effective optical zone. Also, these are sulcus located, so they're much more stable. they can be removed easily, no matter what the timing, how many years later, you can remove them very simply. And there is no tissue damage, no iris damage, and they don't alter the shape or they remove the tissue as is done in case of a LASIK. Now, there are different varieties of phakic IOLs in the market. The ICL is the pioneer, and they are the oldest one and were the most popular ones. There is, of course, the IPCL from the Care Group basket. There is Upper Swami has come up with the RIL, and now you have the latest one, that is the Biotech. Now, my personal experience has been with the ICL from the Star Group. I've done very few with the RIL from Upper, and I have also used the Care Group IPCL. Of the three, I am most comfortable with the IPCL, and over the last 5 years, I have switched over completely to using the IPCL. Now, the characteristic of the IPCL, the incision is 2.8 millimeters. It is customized according to the shape and size of the eye. The correction range is huge, from plus 15 diopters to minus 30 diopters. I have done up till minus 25 diopters. Cylinder is up to 8 diopters. And the material that is used is acrylic material, and there is no porcine polymer, unlike ICL. Criterias are again the usual criterias that you have for refractive surgery: age above 18, stability for at least a year. And when do you use it? Now, there are some surgeons who do IPCL or phakic IOL in whatever may be the refractive status of the eye. But there are others, and I am one of them, who goes for a phakic IOL only when the patient is unsuitable for a LASIK. Also, the anterior chamber depth has to be at least 2.8 millimeters, and the endothelial cell count has to be more than 2000 cells per cubic millimeter. Now, what are the contraindications? There are a whole lot of contraindications, but the most important thing that we look at is the anterior chamber depth, which is also one of the reasons why there are very few hypermetropic patients who can actually undergo phakic IOL, because as we know, in hypermetropia, the AC tends to be shallow, and we rarely get a patient who has an anterior chamber depth of more than 2.8 millimeters. The power range, as I mentioned earlier, was minus 0.5 to minus 30, and astigmatism up to 8. They have also come up with a presbyopic IPCL. As such, I have no experience with the presbyopic IPCL. Preoperative assessment, you do the refraction. I do all my patients, I do a cycloplegic refraction of all my patients. The anterior posterior segment examination, anterior chamber depth, again, that is one of the most important things. The intraocular pressure, and the other very important thing that you have to take measurement of is the white to white. Now, the anterior chamber depth, you can do it with the A scan. Now, depending on your machine, whether you take the depth from the external surface of the cornea or the internal surface of the cornea. If you're taking it from the internal surface of the cornea, that gives you your anterior chamber depth as it is right from the machine, you get it. If you are taking from the external surface of the cornea to the anterior surface of the lens, in that case, you have to deduct the pachymetry. And the internal anterior chamber depth should not be less than 2.8 millimeters. Now, there's something called the vault. This is measured after you have put the phakic IOL. So the vault is basically, by definition, the distance between the anterior surface of your natural physiological lens and the posterior surface of the phakic IOL. And it plays a very important role, as we shall see post-operatively, which is why the white to white measurement that is taken pre-operatively is very important, because that will determine your vault. The white to white measurement, you can take it with an OpScan, with an UBM, or the digital caliper. The most accurate is the digital caliper, but you should always tally it with your other machines. If the white to white range is too short, then your IPCL also will be short, which will then lead to a vault that will be less than normal. And this will have a chance of creating an anterior subcapsular cataract. On the other hand, if your white to white is inaccurate, it's taken more than what it actually is, you'll have an IPCL that's large, that will exceed the normal range of the lens vault. This will lead to angle crowding and thus cause angle closure glaucoma. So the ideal vault should be in the range of 0.250 millimeters to 0.750 millimeters. Now, this is the way you take the white to white measurement. You can take it with a manual caliper, but ideally it's done with a digital caliper. Now, the IPCL implantation, the actual surgery itself, minimum dilatation, you don't want it to be too dilated because you have to tuck it under the iris, but there should be a dilatation of 8 millimeters. Anesthesia, now it is usually said to do it under topical anesthesia, but I myself do it under peribulbar anesthesia because I am not very good at vocal anesthesia on the table, and I really like to stay cool and keep my patient cool. The draping and everything else is just like cataract. Before you take the patient up on the table, the marking, the axis marking is done. Now, the beauty of this care group IPCL is that the toricity is incorporated into the lens. So you only need to mark the 0 and 180 degrees, and you place the lens exactly at 0, 180 degrees. Unlike other lenses, you do not have to, dial the lens 10 degree this way or that way and, take another marking for the toricity. The toricity is incorporated into the lens, place it 0, 180 degrees, and you're done. IPCL is injected through the injectors, and if you look at the IPCL, you'll see there are some, first and foremost, there are 6 foot plates, 3 on each side. Now these foot plates, they increase the stability of the lens. This is the newer version. The older version had only 2 foot plates and was a little unstable. But this version, which is called the version 2, has 3 foot plates on either side. So the stability is much more. They have these holes which allow the pressure to be equal on both sides and also allow the visco to come up. The newer version has the version 2 has come up with a central hole. So now we don't need to do a PI prior to surgery because you can take out the visco through the central hole. And there are these 2 extra holes at the junction of the aptic and the haptic. And these 2 holes determine your alignment of the lens. The alignment is very simple. The surgeon always sits at the temporal side of the patient. If you're doing surgery in the right eye of the patient, the 2 holes have to be on your left-hand side or the superior quadrant of the eye. And vice versa, if you're operating on the left eye, the 2 holes have to be on the right-hand side of the surgeon or the superior quadrant of the eye. And if the vault is upwards, you cannot go wrong. Your lens will be perfectly placed. So again, open the cartridge, fill the injector with saline and with your visco. Open the IPCL container, lift the IPCL very gently with McPherson forceps. It is a very fragile lens. You don't want to damage it. Check the orientation of the IPCL, very important. I usually place it on my palm to check the orientation and then place it on the cartridge and put the cartridge into the injector. The folding of the lens is very, very simple. Another reason why I prefer the IPCL to the ICL. Surgical technique, you do paracentesis, put viscoelastic. I have the video, so I think I'll proceed with that. As you can see, the marking has already been done here. And I like to again check the marking and make it a little darker because sometimes with all the cleaning and everything, the marking becomes a little light. So I'm checking the marking, they're almost perfectly done. And that is my paracentesis. This is one of my very, very early cases. And believe me, during this stage, I used to be really a little jittery while going here because despite the fact that you have a good deep anterior chamber, it's a myopic patient, there is still that constant fear that you have, the virgin lens below and the absolutely pristine cornea above, and you just have so much space to do your work. So making the clear corneal incision. And the amount of visco that you put in should just be adequate. Don't put too much of visco. Ideally, it is said you should put in visco till you see the very last thread of the visco. Do not let the threads, sort of disappear. Be there till you can see the visco. This is the lens. Lift it up very gently with your MacPherson. Try not to touch the optical area. Check for the orientation. I always put it in the palm of my hand and check for the orientation. This is the injector. See that it is inside the grooves, that no part of it is above, because if you close the injector and any part of it gets stuck, it's stuck there. It's, as I said, it's a very fragile lens. So during the movement, it might just crack. And when you're closing the injector, listen for the click sound. If there is a distinct click sound, that means no part of the lens is caught there, it's in the groove. After I put it into the injector, I always check to see that the movement is free, that it's not stuck anywhere. So on both sides, I check to see the smooth movement. And once I'm sure about that, again, as you can see, I'm putting in some visco, but as I said, this was my early cases. You really, really do not need to put in so much of visco. And here I'm going in and very slowly pushing in the lens. Now, the technique of pushing in the lens is that you do not push it in one go. You push, you stop, you push, you stop. This sort of helps the lens to unfold very slowly, and you watch for the unfolding. And at any stage, if you suspect that your lens is going to topple over or it's turning, you can just take it out. It's very simple to take it out and then reinsert it again. So this is the technique of doing it. Push and stop, watch for the lens to unfold. And as you can see, the two holes, this is the left, this is the two holes that were there. It is now on the right-hand side on the superior quadrant. And I'm going in with the lens tucker and very gently pushing it in. Now, what has happened in this case is that, it's the iris has sort of, it's not exactly as much dilated as I would have liked it. A little more dilatation would have helped me in tucking the lenses quicker. But so I'm having a bit of a struggle here, but I'm able to do it quite comfortably. And once the haptics are tucked in, you just have to ensure that it is aligned. There are 3 markings on the optic haptic junction that has to be aligned with the markings that you have made previously. And now one very important step, and that is to take out all the viscoelastic. You have to be very sure that every bit of viscoelastic has been taken out. Otherwise, this is going to cause a rise in pressure. Unlike in cataract, sometimes a little bit of viscoelastic is left behind. It doesn't cause such a lot of damage. But here you have to take out. So I watch for the last thread of viscoelastic to come out, and then I still wait and do a little bit more of aspiration. And then just like cataract case, you just close your wounds and that's it. So a refractive surgery is a very, very satisfying surgery. And as one of my patients has said that, it's a routine surgery for a refractive surgeon, but it is a life-changing experience for a person who has been wearing glasses like -13, -15, -25 for most of her life, and then to be able to see without those thick glasses in front of her is really, really life-changing. Thank you so much for a patient hearing.
Thank you, Dr. Doyle. A refractive surgeon you are. The positivity that you have shown that in this presentation, you have shown everything that's possible in a IPCL or the phakic IOL. I think a lot of users now, we have IPCL users all over the country. So anything to add, Dr. Rajesh? I would like to ask you something, right? Like you said, 1 or 2 key points that the pupil has to be dilated. You felt that, you were brave enough to show that, it looks very easy, just push it and go in, the lens will go in. But then if the pupil becomes small or by some way, you have a mid-dilated pupil, do you put the ends right under the iris and then try to do it? And number 2, what viscoelastic? I think people would think that putting a Helon is or any high molecular viscoelastic versus the low molecular, the common methyl cellulose. Yes, please.
Yes.
Doel?
Me? You asked me?
Yeah, let's hear Doel and then Rajesh will
Okay.
come.
Okay. Yeah.
First, about the viscoelastic, I would prefer low molecule viscoelastic, because if you put in Hilon, yes, your AC is formed and everything, but while removing it, if you're not able to remove it at one go, the entire molecule, then you could be in a bit of trouble. And actually, with experience, what I've found is, as I told you, this was my initial cases, so I put a lot of viscoelastic. But you do have a very deep chamber, and that huge amount of viscoelastic you really don't need to put in. So with experience, I don't think viscoelastic plays that great a role in sort of keeping the chamber deep or anything. The other thing is about, yes, when your pupil constricts, it becomes a little difficult. What I try to do is I try to put in the visco above the lens, especially where the haptics are, and then I go right up to the end and dip the haptics. Dip the haptics and sort of dip it and push it under the lens, under the iris. But yes, it is a little difficult, takes a little bit of maneuvering, takes a little bit of experience, but it can be done. It can be done no matter how much your pupil constricts.
Thank you. Thank you. Yes, Dr. Rajesh, anything to add?
Yeah, I would like to add one thing, that if the pupil has become small intraoperatively, then in that case, I have described a technique of bimanual implantation of phakic implant, which I have just, we have a good case series and a large number, and we sent it for publication to JCRS. So what we do is that at the optic haptic junction, with the, say, left hand, I will use the Sinski hook to engage the perioptic hole. Hold it and bring it towards you, and then tuck the haptics. Very easily it will go underneath. Similarly, on the on your side, that is on the temporal side, you hold it again, the perioptic hole, bring it towards the nasal side, and then you can easily tuck it in. So this is the technique of bimanual implantation of phakic IOL in a small pupil, in a intraoperative meiosis. This is one. Number two, yes, viscoelastic can be used, anything can be used. Some people prefer Hilon or whatever, but I use methyl cellulose. And over the last few months, I have actually stopped using viscoelastic. I do hydroimplantation of phakic implant. Initially, I used to do it for toric, for spherical. Now I've also used it for toric and for RIS, for Icril, Biotech, and IPCL, everything. I have used this technique of hydroimplantation. It works very well. The only thing is, one query is that, although I've done it successfully, but one query is that if you have to rotate the lens, there is no cushion between the phakic implant and the
lens.
zonules.
Zonules, that's what is bothering.
Yeah, so in a toric lens, whether I can advocate that, that is something like I have, my paper was presented in last ESRS also, but I have put only the spherical lenses. Now for rotation, although the rotation is hardly required in ICLs also, because cylinder is incorporated in ICL also, but only thing is that you just have to rotate 1 or 2 degrees or 5 degrees to adjust, because you don't have that much of inventory. But these Indian companies, the hydrophilic acrylic lenses, they have so much of inventory that they can provide you the exact. That's why these are called smart implants, smart phakic IOLs. So that is one thing which I still am not sure whether I can advocate, that you put the phakic implant, and when you are using the hydro cannula, the cannula is not going beneath the phakic implant. No, it's above that. So whether rotation I can advocate that, I'm not sure. But yes, for spherical implant, very easily you can put it, because it helps in tucking the foot plate very easy. You just divert your fluid towards the foot plate, and that foot plate, and you just handle it, it will immediately go inside. So tucking the foot plate is very easy when you are doing hydroimplantation. The only thing, as I said, that I have done toric implants, but whether I can advocate that rotation, if it's significant rotation of 5 or 10 degrees, whether I can advocate that, I'm not too sure. Because for that, I need to know that whether the zonules are getting damaged by that or not.
Or not, yeah. And whether it's rubbing against the against
Absolutely.
the
Yeah.
anterior lens capsule. That is
Yeah,
the
normally it will not. It will be on the zonules only because it
Yeah.
is so much.
It's
If
a
you look at-
vault is there.
Yeah. So mostly there's some risk of damaging the zonules if you don't have a cushion of viscoelastic when you are rotating.
Yeah, just a question again to Dr. Doyle. Is there a difference between the vault of IPCL versus the ICL, the national one? Is there curvature more or less?
The vault is more in case of IPCL.
Yeah.
The vault is more, and they claim that that is one of the reasons why it's also safer.
Safer for cataract versus safer for glaucoma?
And vault is more, but
aspects.
no, 1 minute. They say that the vault is more, but it's more transitional. The version 2, if you compare the version 1 to version 2, you would see the version 1 was much more flatter as compared to the version 2. But they are saying that as compared to ICL, it is more transitional. That is what they claim.
Yes, sir. Raman, sir.
Yeah, I will only have, I think I'll only comment one thing, that as an ophthalmologist, once in a while, if the things go wrong, you should be honest with the patient, because I had removed one ICL which was put upside down. Iris was totally bound down. So after remove the ICL, pressure was 45, 50 with the maximum medication, then did the trabeculectomy, then did the cataract. I'm sure the surgeon must have realized that things have gone wrong. Just didn't know how to handle that patient, because the cost of the ICL is quite expensive. I mean, if you're going to remove, who is going to bear the cost? So even if you got to pay from your pocket once in a while, you are operating so many patients, I think you should be very, very truthful to the patients. And if the implant has to be sacrificed, please do sacrifice and do whatever is required to be done.
So I'll come in here 1 minute. No financial interest here, but this is another reason why I prefer the IPCL. They actually give you a backup lens. The patient pays for one lens, but they send us 2 lenses. So if for any reason, and I usually on the table, the surgeon is able to detect if the lens has turned, and if it has, you can take it out. But I also know of cases where the lens, it turned and it was there for a week. And luckily there was no cataract formation. The vault was only 50 microns. And it was taken out, and again that backup lens was put in.
So Indian companies that way, I mean, even if they need different power and different size, they will make it complementary for you. I don't think there's any problem with the Indian companies. Anytime if you are using their products, they'll be more than happy to do that. So
but even these Collamer lenses, sir, it can be removed very easily. You hold not in the middle of the foot plate, hold on one side. So just pull it. What I explained to my resident is that you can't pad ke bahar nikal enough. So you just hold it on one side, it squeezes, and by holding and reholding, you just take it out. It is not, you can reimplant. And
yeah, I know. I mean, just saying that in all these surgeries as a surgeon, I think anything goes on, you must inform the patient immediately.
Absolutely.
I mean, there's no point, whatever surgery you are doing, you should be truthful and honest to yourself. It will give peace of mind. And patient, I mean, unnecessary patient will not go through severe complications.
Thank you.
Because ICL is a cost is involved.
Yeah.
You really get worried whether patient will pay for the second ICL or not, going to bear the cost. Because the surgical fees is less than the cost of the ICL itself. That becomes a little dicey. So even then, even if money is going from your pocket, you should be truthful to the patient. That's your
absolutely.
Thank you. So thank you, Doel, for that lovely insight into the whole world of phakic IOL. So we go to our last speaker, Dr. Swarup. Dr. Swarup Rai is a prolific surgeon from up north of Bengal. He is from Siliguri, from the Himalayan Eye Care Center, a prolific surgeon over there. So he'll be talking, adding to what Dr. Rajesh was saying with the hydroimplantation. He is putting the hydroimplantation after cataract surgery, which most of us have now part of our practice, and we know the advantages, especially in the toric IOLs and all those premium lenses. Yes, over to you, Swarup, please.
My screen is visible?
No, not yet. I think
you haven't shared it.
You haven't shared it. No. It is not yet shared. Yeah, that's great. We can see it now.
So as Ajay was saying, nowadays, I think many have adopted IVL implantation under water, no, in not using visco, but there can be issues. I'll go through some of small clips of videos and let us see if there are issues involved there. Now this, carefully see there is a break in the cartridge. Can you see there is a break in the cartridge and water is rippling out. So in these cases, sometime you may have this tight IVL in the cartridge can hit very hard on the other side, and it can even sometimes cause issues like injury in the iris or injury in the or PC rent even, or equatorial injuries all can be there. Now see carefully this one. You see there is a shooting of the IVL, and you can appreciate the posterior capsular stress lines very carefully. See? So this actually may lead to a PC rate and IVL can drop even. This case, luckily, nothing happened. Now, the loading of the IVL, no, is not proper sometimes. Your leading haptic is just pointed like a gun. You have to rotate carefully. A skilled hand actually get away with all this, but sometimes learners, beginners can have problems. So in that cases, you did not to go and put this IVL if you are not sure that you'll be able to put. So beginners actually should do that cases under visco delivery. The IVL after the insert can rotate like that. So this can sometimes cause some injury in the cornea, back of the cornea. But your second instrument, that is your irrigation port, that is on the other hand, should guard. As for example, here, once the IVL was trying to rotate, as because the leading haptic has not gone in the bag, and the second, that is the irrigation port has not supported the IVL very well, and then you can have these rotations happening. And you can stop the irrigation for a while. The rotation will stop. I can just show as the rotation started, the irrigation now, yes, stop the irrigation, the rotation stops. So you can go ahead now with the surgery. IVL can flip. You can notice here that the irrigation port is little bit away from the IVL. So there is a chance that time that the IVL gets flipped. Frequent gateway in many cases without any problem, but there can be issues. I will show. You have to guard with the irrigation port. Even if there is a tendency of rotation of the IVL, flip of the IVL, you can guard and guard the cornea also. You can get away. But even then, rotation during this time, no, you see the haptic may be rubbing your cornea. So be careful in these cases. Don't be very much daring. You must put a viscoelastic and protect your cornea well. Here the IVL flip, you can see is quite a bit, almost full. The trailing haptic is yet not unfolded. So there is a chance yet you can do maneuvering. This can come back. You have to be very, very careful that you do not rub cornea. If you feel there is a problem, then you must not go ahead, put a viscoelastic and do. Here you can see the IVL flipped, and even these haptic have unfolded. So when there is engagement of both the haptic gone in some places there, you cannot rotate. You cannot flip back. It is extremely difficult. So it is always recommended that you put these elastics well, and then you can well maneuver this, put in the place. Here, sometime IOL implantation, if you sometime you think that this has stuck the in the iris, it has not gone in the bag in the first go. And this haptic, this is hydrophilic lens. So this haptic sometimes touches cornea and can cause problem. So in these types of haptic, you have to be very careful putting these IOLs under water. Sometimes your trailing haptic may remain outside. Sometimes difficult because the AC is collapsing. Sometimes the water comes out. Little bit of difficulty can be there. You have to be very sure that leading haptic has gone in the bag. Now see, it was not gone. Now it has gone to the bag. So it's sometimes confusing. The haptic has remained outside. This happens mostly in wound-assisted deliveries, and it is sometimes difficult to put in this trailing haptic. And once your people is becoming smaller, AC maintenance is poorer because of the leaking wound. So many a time you have to struggle quite a bit. So do not wait, put viscoelastics very nicely and then go ahead with the surgery. Too much of struggle will cause a lot of problem there. In this case, as the optic haptic junction has just stuck the iris, patient squeezed and the whole pupil became small and the eye will remain vertical. And it is disengaged from the wound. As it has been disengaged, the eye will automatically become flat. But this has caused a line of endothelial injury here, where it was stuck in the vertical position. So this can be dangerous in many patients. So in topical anesthesia, it's also an issue. Like this water delivery is also an issue, and you are taking chances in many patients. So you may have to face such a problem in many cases. IOL stickiness can be bothersome sometimes. These are some of the issues you always face, but this is not a big issue. This you can wait for 30-second, 40-second time and get away with this stickiness. It goes. But here is a case. This is a little bit longer video. I'll shorten it. See, this haptic has stuck on the behind the optic. Behind the optic. I was trying. It was underwater delivery. I was trying to disengage and detach this attachment with two instruments on both the irrigation aspiration port. Used viscoelastic now and tried with two separate instruments of spatula and the Sinski hook and made the IOL vertical and gone in between this junction in the gap between these two to detach this attachment. It is so stubborn that it is not getting detached. It is so difficult. It took about 3 to 5 minutes time. See, you can see it is literally tearing off, as if I am tearing off the IOL. It is not coming out yet. This is a acryol EC IOL that I implanted, and from that experience I have avoided using this. No doubt this has happened because of increased stickiness they have put in the back of the IOL so that the PCO rates are less. But this has caused this a problem. because I will the cartridge loading sometime can cause these are loaded by the assistant most of the time. So you may land up such a problem. I think you can appreciate such a struggle that I have to do, and it is not yet opened yet. No, this is the time. This is last part. Now it has released. So upside down the lens was been made, and then it has gone. So difficult sometimes. So underwater delivery can be even bothersome in these cases. So the main thing is putting the cartridge inside. It is better to put be in the inside and guard the eye well with the irrigating port, and then put in the eye well. In this type of haptic, also see the leading haptic has gone well in the inside, and guard the eye well before it unfolds, and then you can tuck it into the bag. So thank you.
Thank you, Dr. Swarup. I think showing us those plethora of cases actually shows the prolific surgeon you are, and your wide experience in dealing with this and how we have come. I think the last slide showed it all, the simple trick, how to, the beginners, how to get through that, especially guarding it. And I just add to that, just at that moment, I would put the irrigation just off. The ear would come to foot switch almost zero, because if I have that, and that moment, as it is opening, you just allow it, and then again get the irrigation on. Then you see that the lens has gone and settled in the bag, and then get it. And the second thing, the manipulation that you are doing, I think over a period of time, I've learned that the irrigation is on. Instead of take the aspiration in the right eye, you can just take not the Sinsky or the lens manipulator. It becomes much easier, especially the haptic going over the iris, and you're trying to, push that with the aspirator. Instead of that, just I will manipulator, one of the manipulators, just hold it and take it and work. But then you have really shown the whole plethora of cases, and especially those sticky lenses that can be real sticky in case of irrigating, putting under irrigation. Any comment? Yeah, Arman sir, and we have Satyajit also.
I think one is that the second hand you are using a rounded irrigation port, which I use usually double dialer, which you can engage at an optic haptic junction very easily for rotation. Secondly, like in handshake technique, when my IUL haptic, trailing haptic comes on the end of the tip of the injector, I use the irrigation port at that time and guide it then and there into the chamber. Yeah. And if I feel there's any problem, I just place it onto the rhexis margin and just press it down. It gets slipped inside. And while injecting this hydrophilic IUL, you need just 50-60 centimeter of bottle height. You don't need 100 centimeter. Yeah, so that this actually you are able to control the rotation and the shakiness of the IUL better over there. That's just 1 or 2 points. But otherwise, overall, very
overall
good.
It is.
And I'll take leave. Somebody's at my home. So thank you very much, everybody. And bye.
Thank you. We almost come to the end of this program, and I just add a little bit. But in the chances of the lens tumbling and floating in the anterior chamber is mainly in high myopes. In those cases, actually, I put just before putting, I put a little bit of visco inferiorly in the fornix and let the lens go in. And once that goes in, I press it, then the visco anyway escapes. The visco is not behind the lens, actually guiding and keep it. And it's only in those very high myopes that it becomes very difficult.
In my all cases, I do not allow the chamber to collapse at any stage of the surgery. That means when I finish the irrigation aspiration, before I withdraw my aspiration port, I always inject some amount of viscoelastic from the side port so that the chamber is maintained throughout this thing. So already there is some amount of viscoelastic, which is very small, but then it comes out by the time the lens goes in without any aspiration.
Yeah. Before we end, would Dr. Satyajit like to add anything?
I just wanted to share my experience, what I had today. I was using a high-end injector system which has come recently in the market, in which it has a button which you press and the lens starts moving by itself forward.
The Alcon lens, the Alcon
autonomy lens. Yeah, I had given high promise to the patient and it was a +8 diopter lens. I don't know whether the thickness of the lens had to do anything, but the blue pushing stick which is there, the injector, that went over the IOL.
Over the,
And
it has
that
happened
was
with me
I've
also.
been using Clarion 2-3 every day. First time it happened that it went over the IOL, and then I did not know what to do. There is no way you can pull it back or do anything. Then my OT assistant said there is a flap on the top. You just open it and then take out the lens and then
Put
use
it in
another
a
injector and
simple
put it in.
injector.
So that was one experience which I wanted to share, because I was just panicking that after finishing a high myope phacoemulsification nicely, I was not being able to put the IUL. So even that can happen in Clarion. I did not anticipate that.
This happened to me 6 months back. After that, I always have a simple IQ as a backup. It happens to me. Anyway.
But my OT assistant opened it very nicely,
the
end part, and took out the lens and.
Yes.
But very nice videos, sir. Dr. Swarup, sir, very nice videos.
Very, very
Thank
nice
you.
video. Very,
Thank you. Thank
I mean, you have something like 20 videos. I don't know how many, even more than maybe 20, 30 videos you had painstakingly you have. And so I think we are, Dr. Rajesh is not here. Dr. Rajesh, are you here?
No. Yeah, I'm here. Yeah.
So
Very
anything
nice
to add
videos
and
just one thing, with whatever experience I have, what I feel is that when we are doing hydroimplantation, the direction of the fluid matters a lot. So if the direction of the fluid, say if we are sitting, it should be inferior angle, towards the inferior angle. Like if we are doing temporal, then it should be on the nasal angle so that the chamber is well formed. And plus, if the direction is towards the center, then it may flip the IO. So that is one thing which I have felt that should be done. Otherwise, it was, very good cases, wonderful, very interesting ones, and very nice videos. So I must congratulate, and I would like to thank Dr. Ajay for moderating the session very well. So if we are done with the discussion, then maybe can I do the duty of thanking everyone?
Thank you.
So, big thanks to the chairman, Dr. Hermanslal, and of course, moderator, Dr. Ajay Paul, who really brought out some very pertinent questions, very interesting presentations. All 4 presentations were so crisp and so good that, this webinar was very interesting. And we had a wonderful discussion. Thanks to Dr. Ajay. So thanks to all the speakers, and would like to thank Ilargan for supporting this webinar. So, and I would like to thank all the audience, all our colleagues who have participated in this webinar and making it successful. So thank you very much, and hope we will see you again very soon in some other.
Thank you, Dr. Rajesh.
Thank you, everyone.
We hope to see you more and more in the AIOS for more times to come. And there's Satyajit also. Thank you.
Thank you so much.
Thank you.